name's Scott Drummond. I'm the Program Manager at VADA. If you've just joined us from another session, or this is the first time you're joining us today, may I pay my and our collective respects to Aboriginal Elders past, present and emerging. Welcome to this breakout session, Co-Designing a Drug Alert Prototype for Victorian AOD Clinicians, brought to you by Rita, Brien and Isabelle Volpe. May I introduce Rita. Rita is a Research and Education Officer at Turning Point and Assistant Lecturer of Addictive Behaviours at Monash Uni. Over the last decade, she has worked in research and project coordination across public health, higher education and the AOD sector, with research interests in the social and political context of AOD use, which I love, new and emerging patterns of drug use and promoting best practice harm reduction strategies. Rita is passionate about evidence-based information sharing that builds capacity for delivering sensible and compassionate interventions. Love it. Hi, Isabelle. Isabelle Volpe is a research officer at RMIT Uni. Her qualifications include a Bachelor of Arts, Psychology and Sociology, and honours in Psychology. Isabelle's research activities have focused on AOD treatment and policy. She is currently undertaking a PhD at the Drug Policy Modelling Program at the University of New South Wales, Sydney, with a focus on policy, participation and young people's drug use. Isabelle also volunteers with the Loop Australia. Welcome, Rita. Welcome, Isabelle. Over to you. Thanks for joining us today.
Thanks so much, Scott, and hi to everyone. I'm going to try and talk and share my screen at the same time. Good to see some familiar faces and some not so familiar names. Really appreciative here to talk to you all about one part of a project that I'm working on with my colleagues at Turning Point and RMIT. I've got Isabelle with me here today who'll be managing the chat. And just wanted to point out that although this is an RMIT-led project, our team of investigators includes multiple Victorian agencies across health, government, peer and AOD workforce perspectives, as well as researchers. So just to reiterate what Scott said, and suddenly my prompts won't work, there we go. I would like to acknowledge the Wurundjeri Woiwurrung people of the Kulin Nations as the traditional custodians of the land upon which I live and work near Merry Creek that you can see in the picture, and just recognise their connection to land, waterways, culture and spirit, pay respects to elders past and present, and offer respects to all the First Nation language groups across the land you might be seated on today. So we're going to whiz through a quick introduction about public health drug alerts, talk to you a little bit about background of the project Rapid Drug Alerts for Victoria, so that we can explain the process that we've undertaken to co-design a drug alert for AOD workers, so that we can present to you today the prototypes hot off the press that we have come up with, and get your feedback. So it will be an interactive session today. You will need your phones if you want to participate in the interactive side of things. You don't have to, but just a heads up there, keep them by your side for the second half of this session. As I said, Isabelle's here to manage the chat. So if you do have questions or feedback as we go, please pop them in there. We're aiming to have some time for discussion at the end, but if we run out, we will be saving the chat. So we'll be able to take your valuable feedback on board and integrate that into our findings. And any feedback that you do provide through the interactive session, it will inform our final prototype design and results that we will be publishing. So just keep that in mind. The chat's not private and we will be using the anonymous feedback. So drug alerts, they're basically community or health warnings about unexpected changes in unpredictable illicit drug markets that have potential to cause significant harm. Obviously, they're aimed at increasing awareness of dangers to prevent avoidable illness, injury or death, although in the current climate, they do often arise after a serious incident has occurred. Essentially, they tell us about one of two things, really, either a detection of a high-risk substance that's circulating in a drug market, or more generalised shifts in availability, purity, or strength. And in an ideal world, alerts will provide us this information faster than the usual time lags we're used to seeing in traditional drug trend data reporting systems. And although a universal and coordinated approach to monitoring information and managing and communicating this type of info here in Victoria and Australia is an absolutely huge job, and it is still a work in progress, but alerts do get sent out. And here are some examples of alerts that have been sent in the last 12 months here in Australia. Hopefully some of you have seen some of these. Our research has indicated actually that up to a third of AOD workers haven't seen an alert in the last year. So we know they're not always reaching workforce effectively. And as you can see from the slides, there's a bunch of different, there's no single format, design or source of information. So they're sent from multiple agencies, they're designed with different audiences in mind, and they take on very different forms, use different media, and have different messaging depending who they're for. So what we were interested in, or are interested in, is what actually makes a good alert, and specifically what makes a good alert, a clinical alert for professionals like you guys, who might be best placed to help prevent harm and or respond to acute harms in the community. And there is literature emerging for this type of risk communication. Most of it's direct comms to people who use drugs themselves. So there's limited info specifically about local markets in Australia, local alerts in Australia and for clinicians specifically, and even less sort of evaluation of their clinical value, which takes us to the project. So this project is funded by the National Centre for Clinical Research on Emerging Drugs, and it arose because an opportunity was identified, or the potential utility of existing forensic drug seizure databases to support alerts was identified. So Rapid DAV, as we call it, is aiming to translate signals of risk arising from forensic drug analysis data directly into alerts for clinicians or workers in AOD and emergency healthcare. But to be able to demonstrate and evaluate the clinical value of forensic data and the alerts that get sent from it, we first really needed to understand what a successful clinical alert looks like, right? So we engaged in this co-design process to come up with what the ideal alert template would be. This part A of the project ended up being a much bigger process than we first anticipated. Part B is absolutely ongoing, but today we're focusing on our co-design process and results. So we initially sent out a scoping survey last year to help establish need, context, relevance, appetite for clinical alerts. And you can see on the slides that the majority of the respondents were people working in a number of different AOD roles, either as managers or workers, and a smaller number of people from urgent care settings, so emergency medicine, first responders, that sort of thing, and an even smaller group were across both sectors. The survey results demonstrated universal support for drug alerts. Many workers didn't think that access to timely information about drug workers was adequate for their roles. And told us lots of other things too that we don't have time to go into today. And it also helped us recruit for the crux of the co-design, which was our 4 workshops that we ran. And also we were able to enrol 152 workers and clinicians ready to receive alerts and evaluate them in part B of the project. So, oh, my screen's just wigged out. There we go. What do we actually mean by co-design? So basically it's creating a product in collaboration with the people who are going to use it to make sure it's relevant and useful. So we really wanted to engage in this consultative exploration of problem to learn about drug issues that workers faced related to drug alerts, so that we could define what we needed to do to make a successful alert, but also use the expertise of the groups that we were talking to generate useful ideas for the design. And that's what we've done. And we've come up with some prototypes, as I said, that we'll be showing you today. And we're now at this sort of testing the alert phase. So this is where we need to get feedback and fine tune and tweak it. And throughout this process, we covered a lot of content, heaps of content, so many robust conversations to identify the different elements we needed to inform alert design and what to include and what it should look like. And we did identify a number of opportunities and challenges that we needed to consider. It might be no surprise, but although we set out to design an alert specifically for clinicians, we established really quickly that there's a number of non-clinical stakeholders who benefit from drug alerts. And tensions really started to arise when we started teasing out the competing needs of the different clinical and consumer stakeholders. So even within groups of clinicians, there were different levels of drug expertise, health literacy, technology needs, and depending on the person's role, either their work environment or their place in the community, they had different needs for the information that we needed to include. So it became really clear very quickly, pretty much everything about the alert depends on who the alert is for, but the audience is everyone, not just clinicians or workers. And workers were adamant that we had to share the alert, or the alerts needed to be shareable with people who use drugs, which is kind of a no-brainer. It makes no sense to gatekeep information for the people it's intended to benefit. Workers weren't interested in repurposing alerts to make them shareable. They're too time poor. There's risk of diluting the messaging. So the alert really needed to be equally relevant for communities of people who use drugs as well as workers, but still fit within the auspice of the clinical alert that we were designing, because that's the project scope, right? So we were mindful that we did have peer voices in the discussions and in our investigator group, but our co-design was clinician focused and not consumer focused. So we couldn't design a specific alert for people who use drugs, but we could keep their needs in mind when designing what we were going through. And that really meant striking the right tone, getting the messaging right, focusing sufficiently on risk without scaremongering, avoiding unintended consequences like accidentally promoting drug use, making sure we weren't being condescending or stigmatizing. And we were really challenged with the balancing act of having all this comprehensive information, but being concise and clear and cutting through information overload. Yeah, we were sort of trying to find this one size fits all approach, but it's not really possible. But we have given it a red hot go within all the constraints that we've identified. And one way to do that and to resolve some of the challenges was to make sure the alert was available on multiple platforms. So our groups told us that email and SMS were really the preferred methods for receiving alerts. It was abundantly clear that even though a website might not be sort of the first point that you would learn about the alert, and the website needed to exist to house more information and make alerts easily accessible all in one place. And there was appetite for other types of communications like a drug alert app, that sort of thing, but that wasn't within our scope. So we've taken that on notice for the future ideal scenario. So let's take a look at what we've come up with. This is where we will get you to get out your phones if possible. And hopefully I can't actually see you guys whilst I'm doing the presentation, but you can also contribute via the chat. Bear with me one sec, I've just lost my place. What we've done is we've come up with an alert scenario based on a real scenario that was sent out from New South Wales Health in May. I have Victorianified it, but I just want to be really clear that the scenario presenting today is hypothetical, not currently happening in Victoria. We've come up with 3 different levels of information in three to four different prototypes. And we're deliberately not giving you the context of the situation before you see the alert, just to get a bit more of an organic response. So as I said, this is where we would love it for you to get out your phones. There's a couple of ways that you can access the interactive session. We're going to do some live polling. So we'll show you some alerts and then we'll get you to respond on your phone to the live questions that will come up on your phone. And then you should be able to see the responses live on the screen. Apologies in advance if you've rung into the meeting, you should still be able to participate, but it will be a lot easier if you have a screen in front of you and you can look at the screen and your phone at the same time. So scan the QR code on the screen in front of you and it should take you directly to the menti.com page. Otherwise, you can go to the website that you can see on your screen and enter the digits. You don't need to put the spaces in. And I just want to point out to everybody that if you are participating and answering questions through this process, we will be assuming that you're consenting for us to save your anonymous feedback. It won't be identifiable, and we will use it to inform the project and our research results. It looks like it's working for some of you. So what you should be seeing on your screen is a prompt to tell us what you think about pineapples, but it's currently not opening, so I'll need to open it for voting. So before I do, I just want to give people time, and if you are having issues, just dump some notes in the chat and or press spacebar and speak up. But as I said, there are other ways to contribute if it's not working out for you. Once I open up the live voting, you should actually see a couple of statements and coloured dots underneath them. We want you to tell us what you think about pineapples. This is obviously just a test question to make sure that you can figure out the technology. So what we want you to do is use your finger to move the dots. Some of you are getting the gist already. And once you tell us what you think about the statement and then click the green submit button. So we've got about 15, 16 of you in there already, which is fantastic. And if you look up at the screen that I'm sharing, you can see that the majority of the groups seem to be pro pineapple. We've got a little bit of controversy sitting here on the pineapples belong on pizza or not. Good to see. What I'm going to do is just give you guys 10 more seconds. If anyone's having any issues, speak now or forever hold your peace. Isabelle, is everything looking okay?
Yeah, I'm just DMing one person.
Cool. So now you will see on your phones again that voting has closed for those of you who've managed to get through. As I said, if it's not working out for you, no mind. You can dump some comments in the chat. We'll be saving it and we'll come back to it later. So now that we're coming back to the slides, I just want your attention back on the screen again if we can. And we're going to move to our first prototype. So as I said, workers told us that SMSs were probably a very useful prompt for clinicians who are out on the road a lot, don't have access to internet or the email. We had one worker saying, you know, they'd only just received smartphones during COVID, so really would never have access to emails on the road. And we know for many reasons AOD workers don't sit in front of their emails all day long. Also, from an outreach worker's perspective, it was pointed out that having text messages that could be sent on to people would be really useful. And, you know, even for service users who aren't necessarily engaged with services at the time. So our first challenge was coming up with a message in 160 characters or less that provided sufficient prompt for somebody to then go and access more information about the situation if it was relevant to them and or the people they worked with. And I'm just going to read this out to you. So we came up with drug alert, Victoria, long-acting opioids present in cocaine, risk of unexpected opioid overdose with non-opioid drugs, know how to respond, and then link to access more information for those who obviously can get to a website either immediately or later. So this is where I want you to switch back to your phones as I switch through to the slides, and you should get a notification at the top of your screen that the presenter has changed slides. Come across with me by clicking the green button. While I'm opening the slides for voting, I want you to imagine that you've just received this SMS and then have a quick read of each of the statements about whether you think it is obviously an alert, whether you would share it, and whether it would prompt you to actually access more information. Hopefully you can see that it's open now. I can't see people coming across. Yes, I can. Fantastic. I'm going to give people a little bit of time to respond. We're seeing some positive results there, which is super excellent. You can also skip questions if you don't feel like you're comfortable answering them. So the majority of people are pro this alert, which is super cool. And don't forget to pop notes in the chat if you've got any further feedback. So I'm going to give it 10 more seconds and just close the voting after that. And move back to our presentation. So in the interest of time, I won't chat about, we won't get engaged in too much discussion. There wasn't anything particularly controversial there. And if you come back to your screens, we're moving on to the email. So obviously email was overwhelmingly considered the best way to reach most clinicians, and obviously can provide heaps more detail than an SMS can. Some of the challenges we were faced with regard to designing an appropriate email, it needed to be obviously identifiable and recognizable. And as this quote says, the first quote says, not just another piece of information. We know how many emails you guys get on a daily basis. So it really needed to stand out from the outset, and ways to do that were obviously in the subject heading, as well as having a single, reliable, trustable, credible source of alerts. It needed to include like easily identifiable summary of the information, especially for somebody who didn't have much time just to glance at it and get the gist of whether this was relevant and needed urgent attention or not right there and then, or if there was information that somebody could come back to later. So there was this balance between having a summary of the information, but obviously there's value in having as much information in the email as possible. I don't expect you to be able to read this, and we're not going to ask you to sit there and read through the entire alert, but what we do want to get is sort of just the gist of your feels on it. I will read out just the summary information to provide you with context for those who can't see the small text. So essentially, opioid overdose is linked to cocaine use. Long-acting synthetic opioids have been associated with illicit cocaine. Strong and long-acting synthetic opioids might be present in illicit cocaine. That means there's a risk of unexpected opioid overdose associated with non-opioid drugs. Hospitalizations have hypothetically happened across Melbourne recently, and there's some actions there that we want workers to share with their clinical networks, their patients and their clients or consumers, and other relevant stakeholders. Make sure people know the signs and symptoms of opioid overdose, even if they're not using opioids. And to refer to the more detailed information either in the printable PDF link that we provide, or give some context and background there in the email for somebody who can't access the links. So coming back to your phones, as I said, don't spend too much time focusing on reading this. You should, once I open the question up again, move to the next slide with me. And once I open up the question again, if you do want to zoom in on the image of the email, you can just click on the picture and it should zoom up on your screen. And then to get out of it, just tap back out. I can see that voting hasn't refreshed. Oh yes, there we go. So you can, yeah, zoom in on the picture or tap out again.
I just want to note in the chat, Patrick made a very good point, which is that the Mentimeter starts at 1 as a default. So just in case anyone is not paying attention or multitasking, make sure that you scroll through and make sure that you voted on every single one so that you don't accidentally give a 1 if you did not mean to.
Well, if you don't hit submit, we won't get the results. But yeah, I mean, it will be a strongly disagree by default. That's a good point, actually.
Rita, is this one open? Mine says that this question is not open for voting.
I've got about 10 people in there voting. So okay. Maybe if you just it could be, what you could do is just drag down on your screen to refresh the page. Thanks, Scott. That's a good tip.
Don't know if others have had that problem.
Yeah, no, if you are, you're probably not the only one. Got about 14 people in there, so not everybody's in, but we may have lost some of you. So I'm going to give it another few seconds, maybe 30 seconds or so. Did anyone else have any questions or concerns while we're here?
Rita.
Hi, Patrick.
Hi. I did have a thing. I'm sure you guys have thought about this, but quite often we get, sort of anecdotal warnings from places, and there's really never any indication of how reliable we think that information is. And if you guys, it'd be great to know, I've just written in the chat, a scale between, there are some rumours, I mean, obviously you're going to find a technical way, it's not going to use the word rumours, through to, there have been deaths, there have been emergency department admissions, so that we understand how reliable, because sometimes we get stuff and we think, I don't know, I reckon one person mentioned this to someone.
100%, you've hit the nail on the head. That was one of the huge conversations. So I couldn't go into the detail of all the stuff that we covered in the workshops, but a big thing was credibility, reliability of information, evidence of harm, evidence of incidences. So that was that there has actually been hospitalisations. This process would actually be reviewed by an expert advisory committee. So if there was drugalertsvictoria.com and you were getting an email from them, it would have gone through that validation process. I probably should have made that clear. Thanks for pointing that out, Patrick. You're absolutely right. I mean, there is absolutely value in information you're getting from your clients and information that you're getting through whispers. But obviously that balance of getting it right in terms of sending out an alert because there's a legitimate reason for there to be an alert versus Chinese whispers,
and totally. I mean, peers and people who inject drugs are going to know stuff before anyone else does. Did one person say something, or 30 people have
exactly? Yeah. So in this situation, assume that the data's been validated before the alert comes out to you, and that's sort of the point of this sort of coordinated approach.
Cool.
But yeah, nailed it. And absolutely that balance between not just assuming clinicians know or workers know more than people who use drugs. People who use drugs are generally the experts, but there's even different levels of expertise within that community as well. And that was one of the real challenges, getting the right information, that it's not in disengaging one group, but keeping everybody on board. I am going to move on in the interest of time, unless somebody had something pressing there. Was that you, Isabelle?
I was just going to say, would you mind reopening it for just a second? I know a couple of people just wanted to pop there.
I can, absolutely. I can. I just need to go back to that screen. I will open voting, but I'm going to move on with the presentation as well to the PDF because I am looking at the time and we're 25 minutes in already. So it became abundantly clear that not just email, but there needed to be a printable PDF with more detailed information. It was considered a necessary adjunct to an email because attachments make it easier to print off. This worker worked in emergency setting, put down in ED and underneath somebody's nose to share it with colleagues. And it's also easy to forward on to people. But the flip side of that was we had workers saying that, email mail servers will sometimes block bulk emails with PDF attachments. So we figured popping a link to a PDF was the easiest way to resolve that situation. Again, the PDF that we came up with needed to be absolutely obviously an alert. It needed to not just look like another document. It needed to be printable so it could be shareable. It needed to have a clear and concise summary so people could get the gist immediately and decide whether it was relevant to them to read on. It's got pretty much the same information, but a little bit more detail than the email in terms of harm reduction advice and clinical management responses. And additional information and getting help, and also like a nice little QR code so that people could go off to the website immediately if this was, on a hospital waiting room setting or somewhere else. And it needed to have a clear and logical flow, but the information needed to be segmented in a way that people could sort of hone in on the right information that they wanted and not necessarily worry about bits of information that weren't relevant to them, like, clinical management. So again, I don't want you guys to focus too much on reading all the information and taking it in. I want you to come back to your phones, and actually this time we're going to switch it up. We want your first thoughts on this particular poster or this PDF. I'm just opening up the voting now, and you might need to refresh your screens by dragging down once you've come across to the slide with me. And what we want is just 2 words. I haven't blocked swears, so please don't put potty mouth in there, no potty swearing. But just other than that, be nice, and you can be critical. That's absolutely understandable. Pop in the first 2 words that come to mind. Yep, so busy and informative. You can see words are popping up now into a word cloud. And this will be really useful to help prompt us with how we go forward with the final draft of the alerts.
Just while we're on this page, I'll quickly respond to 2 of the comments we've got in the chat.
Thanks,
so Scott said, can you touch on the evaluation? How to know the alerts are working? So part of the co-design process, but we haven't talked too much about today because time, was that we asked some questions around what do people want from alerts? How will we know that we've done a good job with alerts? What makes an effective alert? And that all feeds into our formative evaluation and eventual evaluation of when we do implement the alerts in the end. The evaluation questions we'll ask will be guided by that. So for example, are people able to get it out to the people they need to? Were they timely? Were they able to do anything with the information? And second one from Simone, what's the difference? Looks so much clearer in this version. Oh my gosh, I know. We would love to be able to just send this out as the actual alert in the email. However, something that came up was that email blockers will block PDFs, especially on health system emails. So we had to kind of have what we called an executive summary in the email. And this is available to link through to. So I guess the idea is we need to make the email as punchy as we can so that people want to go onto the PDF or the other thing that we'll show you. But yes, that's why we couldn't kind of graphically design the email.
Yeah, and also a lot of hospital and or clinical environments won't. You only get you can't get HTML through emails. So I've just closed the voting on that one. There's some really great data in there, and I'm just going to take you back to the slides, whiz through. I may not do the voting on the website, but as we said earlier, a website needed to be like a centralized archive of information in one place to avoid having to scroll back through unwieldy email inboxes to find an alert. And also needed to provide specific information that people who identify as consumers or health professionals could access to get more information. So we've sort of got this template. This is not the final design. This is just a mock-up. Same information that you've already seen in other formats, where somebody can click to download, the printable alert or to forward it on, and obviously access specific information as they need. How are we going for time, Scott?
Could you wrap up in, say, a minute?
Definitely can wrap up in a minute. So we won't vote on the website. We just wanted to get an idea of whether people thought that was important, but we've really established that through the process. Just want to thank everybody. Absolutely invaluable information.
In the chat, which is, can you really quickly do a vote? So maybe like a 30-second vote on the website?
Oh, yeah.
Yep, we can do that, definitely.
Sure. And while you're setting that up, congratulations, Isabelle and Rita and team, on really an outstanding piece of work. What are the next steps?
So the next steps will be to put all this together and come up with the final prototype. We've actually got, to then keep testing it in depth with the people who've already participated in the workshops and the surveys and our collaborators. And then obviously to start engaging in that part B, which is demonstrating the clinical value of the forensic data, sending out alerts and doing that really important evaluation phase to find if it was useful. So that's where we're at. I'm loving that people are still voting. I did just want to do a quick shout out because I forgot to earlier and just say how incredible our participants have been, and the enthusiasm for this project is just a testament to the people who work in this sector and their desire to get this right and get the right information to give it out there to their clients. And if you need to get in touch or you want to participate further, please just drop Isabelle or I a email. And that's it. I'll leave it there, Scott. Just trying to stop sharing.
Well done. All right, so as I wrap up, if there's anything else people would like to say, just quickly put it in the chat so that Rita and Isabelle have got a little bit of additional commentary there, because they're using this opportunity to gather their own data based on this session. So really appreciate that. Anything you want to just quickly pop in. But congratulations, Rita and Isabelle and team. great job, and a very important job too.